Okay, the time is to start. We're gonna start live case and the lecture number 3 and the TAVR and the Mitral TEER. And I'm D.W. Park from Asa Medical Center, and I'm introduced co-moderator Dr. Shih-Hsien and from Taiwan, and I already introduced the panelist. We would like to connect in China the second affiliated hospital of Zhejiang University of the China. Okay, Professor Wang. And
starting now?
Hi, Professor Park.
Okay.
Professor Park, Professor Song. Good afternoon. So nice to see you online. So sorry we cannot attend the big meeting in person. Next year we will be sure to attend in person. So today, yes, work with me. I have several colleagues. Yes, as you know, Dr. Liu is next to me, and
hi, good afternoon.
And several doctors, fellows, and also we have echocardiography and anesthesiologists. So first, I would like to invite Dr. Liu to introduce the case. Dr. Liu, welcome.
Okay, Professor Wang. Dear Professor Park, Professor Song, and the panelist. Yeah, I'd like to introduce the case. Okay, the first slide. And the patient is a 75 years old gentleman, and the patient has the symptom for over 1 month. And the patient has a history of the diabetes and hypertension. The next one. And we can see from the echo, the patient is very severe aortic stenosis with the maximal velocity is over 5 meter per second, and the mean gradient is 66 millimmercury, and the AVA is about 4.44 centimeter square. And there are some calcification in the middle LAD. However, the lumina is okay, so we don't need to intervention of the coronary. Next one. And from the CT screening, we can see the parameter is about 81 millimeter, and the perimeter derived diameter is about 25.6 millimeter. The LVOT is about the 75 millimeter. Next one. And we can see the very thickening of the leaflet and the heavy cell calcification. And the coronary height of the left coronary is not so high, about 7 millimeter. Next one. And the patient is把右边这个点一下啊。And the patient is a bicuspid. So we can see from the bottom of the annulus, we can see right there. Yeah, so we have to clarify this is the type 1 or type 0. Yeah, we can see a raphe, yeah, in the left coronary and right coronary. So we define it as type 1 bicuspid, and a very severe calcification. Okay, next one. Okay, you can see here the heavy calcification, and the aorta diameter, ascending aorta is about 43 millimeter. Next one. And the femoral access is good. Okay, next one. Yeah, so the patient is 75 years old gentleman, severe AS, and STS score about 7%, heavy cell calcification, and a very small left ventricle. And today we will use the Venus A+, and we would like to use the study with the Hangzhou solution. Next one, please. So because the annulus is between 23 to 26, so we will use the 23 for the balloon pre-dilatation, and then see if there's a waste or regurgitation. So if there's a waste and no regurgitation, then we will down choice of the valve size with the 26 millimeter Venus A+. So if there's leakage or there's no waste, then we will, based on the annulus, and we will choose 29 Venus A+. Next one. Okay, that's all.
So, okay, thank you for nice introduction, and we are the invited the world-renowned panelist, and and if I'm gonna summarize this patient, the 75, the male, and the STS score intermediate 6.5 7, and the perimeter driven diameter is 25. So bicuspid type 1 and the heavy calcification, and the Professor Wang is try to do, and the self-expandable venous A plus. And any question or comment from panelists for this patient?
Do we know the SOV diameter? I didn't see it on the
Diameter?
of the sinus of Valsalva.
Yes. Could you show us some information about the sinus of Valsalva and the diameter?
It's greater than 30.
Silence of about 28 and 37.
So the orifice of lemon is not so high, it's low.
Yeah.
However, but the calcification is more severe in the left side, left leaflet. So maybe we don't worry too much about the low orifice of the left leg. So we are going to do the
silence is not so small.
I would like to ask you a panelist question is, for this kind of patient, do you regularly do the balloon valvotomy?
I would,
You do.
with a bicuspid that's heavily calcified, I think predilation is a wise strategy. Here, it seems like using it also to determine your size, but I think just to make sure your valve expands well and you can cross easily, I would predilate.
So I think so. Gradually we have the consensus. For this kind of patient, we need to do the balloon valvotomy. So the two purposes. One is to evaluate the size, how big a size we can achieve during the balloon inflation. So it's very good for selecting the device size. The other purpose is to try to open the calcified orifice, may go for further procedure. Also, we can, depending on according to the balloon inflation, we can have some information about whether the orifice of coronary will be occluded or not. We can predict something. So now I'm going to do the balloon valvotomy. So regularly, how big size of balloon do you select? What is your strategy to select the size of balloon?
So in ASAN team, we usually 2-step down the sizing. If you try to put the 26, we usually select the 20 and something like that. So it's one of the concern is about the very low height of the left coronary ostium is like a 6.9. Any protection for the left main for this case?
对，起波180。
准备了啊。
Okay, what size is balloon? 20. Oh,
起波退出。
okay.
sorry.
Okay.
心跳怎么样？
大家看看，
血压怎么样？血压也没恢复，麻醉科注意。
Is Dr. Liu, can
Because
you comment on the size of balloon?
Because you know
the signal is not quite well.
the balloon was not fixed well. So during the inflation of the balloon was diving into the left chamber. So we need to adjust the position of wire by pigtail. So we are going to put the pigtail again to the blood pressure recover. So because the patient, we need to be care the collapse of hemodynamics because the left ventricular chamber is very small. The valve is very severe tightness. The orifice is very small. So now we try to get the pigtail in. Yes. The purpose is for adjustment of the Y position, try to achieve a good position.
There was a very prominent waist on that balloon.
Good.
Now it's okay. We withdraw the pigtail catheter out. We withdraw. Okay.
So, and James, I have a question to you, and this patient is very low height, is 6.9, and if this patient is your patient, usually do
现在没用采用。
recommend the protection device?
It depends on the sinus width of that
Absolutely.
location. If the combination of a low
I
left
think-
coronary and a narrow sinus would
Yes, Bob.
make protection a consideration.
Yeah, I agree. It depends on the valve size that you choose to use and the SOV width. If the width is wide enough, you have
我的
enough
塞点不
room,
是那么容易，
then the local
因
rehab
为
may
那
not
个
be
洗压很厉害
much of a。problem with self-expandable.
And also, you also be based on the device what you choose, comparing to the very simple about the size of balance mobile is a bit smaller. So maybe for balance mobile, we don't really need to worry about the SOB. And also the balance sizing strategy would also be very different because the size we use in the series the balance size is a bit is larger by one size than the balance expandable.
啊，确实。怎么样？
把衣服叫他们家人脱下来呀。
行啊，你气泡没有？
那个。
Is Dr. Liu and the patient is local anesthesia or general? The patient is a MAC procedure?
The patient is on the general anesthesia.
General anesthesia.
Anesthesia. Because we are worried about the hemodynamics, unstable hemodynamics.
Okay.
So especially when we do the pulse pacing. 差不多这样，不客气。好。 往下滑，可能要有个人配合一下我，你求让我就，好，拉都拉不上。好，准备起步啊！我们把，这我就不管钢丝了，谁帮？
钢丝不用把，
我来，你管钢丝，叫一个人推。
好。
你拿两个手管钢丝。
对，厉害管钢丝。
你就管钢丝，我自己来拉这个。好，准备起步，180。 这稍微起搏一会儿，否则的话，
好，可以，好，打，
哇
，OK，
停起搏。
Okay, you did well the balloon dilation.
升压药，升压药。
Is Dr. Wang and Dr. Liu, can you explain the Hangzhou method? How can you decide the optimal valve size and like this procedure? Which valve size was used for the balloon dilation?
So just now, Dr. Liu showed you one slide, which is explained the Hangzhou solution very well. So hopefully we can show you again the slide.
你把那个幻灯片再照一下。
片那个。So we can wait now for
So show the slide, please.
So we can
So can you see the slide? 下面那个最后一张，前面那张。
我们先放在这里。
前面那一张，最后那一张，刚刚秀出来这一张啊，最后那一张。
So we can wait here for further procedure. We can.
最后那一张。
The patient hemodynamics is quite stable, so we can spend some time to explain the Hangzhou solution.
Yeah.
So would you maximize the slide? Yes, good.
Okay, good.
So the first step is to select the balloon size.
改过了没发生。
So if the patient's annulus is less or equal to 20 millimeter, we will select balloon 23 millimeter. If the patient's annulus is about 23, lower or equal to 26, so we still select.
If there's a waist with no regurgitation,
so we still
downsize.
The 23, the annulus is between 23 to 26. We still select the 23.
23.
I don't think so. It's 23.
Yeah, 23.
Okay,
Yeah.
balloon size.
Yes.
So if the annulus, patient's annulus is about 26, less or equal to 29, we select a 26 balloon as a pre-dilatation balloon.
Yeah. So this patient, the diameter is
During the inflammation with the simultaneous angiography of ascending order, if the patient has clearly waist sign without angio without contrast regurgitation.
Yes.
So
Outside.
then, so we make a decision how big a device we need. So we will downsize. We will do downsize. If the patient has one of two, either no waist side or regurgitation.
Yes.
So we will follow the traditional
Annulus. Based
annular spacing
Yes.
strategy.
Yes.
And how big
For
was
this
that
patient,
balloon?
the so for this patient, we use the 20 millimeter balloon
23.
size with a 23 balloon,
Yes.
right?
Yes.
So the patient, I think we can repeat the angiogram. We can repeat the balloon anatomy.
Yes.
And there was a waist and there was no regurgitation, correct?
Yes, yes.
Yes.
Just downsize one scale. We never downsize above one scale. Before we downsize, we have downsized to 2 more scales, but now we only downsize one scale. So I think the patient is quite meet the downsize criteria. So you can see during the inflammation of the balloon, we can clearly see the waist sign without the contrast regurgitation.
Yes. So we will choose 26.
So we will select the 26.
Yes.
But what is about 23? 26.
Okay.
So regularly, maybe we need a 29 for the patient. If the traditional way, we may need a 29. But for this patient, we are going to use the downside strategy with one scale. So we will select 26.
Okay. Could you show again?
Annual
the
is 25, right?
Yeah.
25.6.
Okay,
Yes.
Professor Wang, could you show again aortogram? Yes.
So for this kind of patient, during the deployment of the device, we need to use the customer overlap.
Can I ask
Strategy.
you some question about the balloon sizing?
Yes, this is Venus A plus.
当时我才转不来。
不要紧，不要紧。好，小心。
Okay, good.
OK，可以了，好，可以了。
So now we move the. We are going to achieve the customer overlap view,
Area corner view.
rural view. So for the patient, the customer overlap view is RAO.
Yes.
It's RAO 5 or 6, hard or 20 maybe.
Yes.
Right?
OK。
Now we
Right, step by step.
Now we gradually to release.
OK。
下去了吗？
那现在
Too deep.
没有，现在还没有。还好，
好，离开了。不是往下 diving。
还可以。
So regularly we start releasing. So when the
照你看一
the
眼。
distal of the device in the middle of pigtail.
Yes. It's a bottom.
During the releasing process, regularly the device will be diving a little bit. But
需要一点低。
not same for different device may have a different performance.
Okay, you try to release at the
For this
bottom
patient,
of
we can
the
say-
pigtail.
要给吗？
Maybe we need as a too high, I think, for that patient.
差不多，角度有点大，它角度比较大。The angulation is large, so 我觉得差不多前面。
差不多。
这样。
So we don't push. We just waiting
不
for
能太深。
the device diving a little bit during the releasing of the device. So
对
we，keep the tension.
我觉得稍微有一点点深。
We keep the withdrawal tension.
And during the release, and you're gonna do usually the facing and the 120, or just not facing?
Yeah, well, use the 130.
Wait here.
Okay,
Stop pacing.
130.
130, 130 beats per minute. Stop pacing. 130.
Good.
你们带起来。
带起来了。OK，继续放对吗？好吧。 继续放啊
This，is a cursive overlap high implantation technique.
有点深了
Good, good.
，Yeah，a little bit deep。
放这里吧。
好，
好，just to stop pacing. So what do you think the position is? What do you think the height of the device?
So I think the position is good. And
就不要
so,
噪音也可以嘛。
so any comment or panel? And
Position is
yeah.
good.
我觉得可以再高一点点。
So and the venous A first is retrievable.
The
or not?
retrievable, it is a first retrievable device made in China. Actually, our team involving the development of the device. So I think from our experience, it is a too low. Yeah, we need a little higher deployment.
3 millimeter higher。
We need a 3 millimeter high. So we would have your comments, Professor Song and other panelists. Welcome your comments.
So and any comment for this? In the
Yeah,
table?
I agree. I think it's low. It could be acceptably low. But if you could recapture and reattempt, it would be better. But what I would do differently would be, number one, if during recapturing, if the system lay over towards the greater curve, you would have a better coaxial with the annular plane. And if not, then the second attempt, like that he just did. The second attempt, I would try to position it on the way forward. You know,
Yes. Compared
not
to
pulling back.
compared to
Yeah, but
ideal
I-
and cursive overlap view and the implantation depth is
2 millimeter
slightly different.
compared with the previous one.
我觉得还可以再上。
Professor Park. So now we lift the device a little higher compared with the previous one is possibly 2 millimeters high.
Yeah.
But the Dr. Liu suggests to a little higher again. So what is your comment?
Yes. So in the I have a question for about the overall the instance of a permanent pacemaker and the before and after you try to do cursive overlap view. Any big change of the overall rate of the permanent pacemaker rate in your center?
10%.
Percent of ppm. Yeah.
10.
10, less than 10. So
Less than 10.
Because we try to achieve the high deployment. So the rate is low, it's very low. So now you can see the EKG strip. The cross width is quite narrow. The cross pattern is quite narrow.
So should we move a little bit higher or just stay
Or
here?
we just deploy. We deploy the device here, or we still need to repeat the lifting. Repeat the lifting.
Okay.
I think it's not too bad where it is. It definitely came up. It may center when it's expanded
再
further.
高一点，这里一点。
现在其实主要是那边还有反流了，那边其实
它
它都来偏
倒，它会倒。
倒了以后，其实也是那个，我觉得可以再上来。
So one more.
Yeah.
Okay. Stop pacing, please. 130.
再
Okay.
上来一点点，就不用拉太多，上一点点就可以，
Good,
不
good.
要拉太重，一点点往死，一点点，不要拉太多往死。
One more try to do repositioning.
差不多啊。
Okay, good.
好了，
好，听起不？
听起不？高吗？其实差不多。
也比前面矮了一点，高了一点。
So and any comment
So
about
now-
the usually
Okay,
we
stop.
try to evaluate system, we try to
That was the first
full
time I
recapture,
think
yes?
we lifted at least 3 millimeter compared with the first time.
So, and the Professor Wang, we have a question about we usually use the Evolut R system. We try to the full capture, recapture, and then the release and some starting point. But this during your procedure, you're gonna do some partial recapture, and then some position was changed and then released. Is that the usual practice?
Actually, either way we can do either the partially retrieving retreat or the fully retriever. So because it's only several millimeters difference, so we like to do the partially retrieve.
Yes.
So we can release, I think. No?
Yeah, Professor Wang, it seems that it's from the non-coronary clasp, the high is perfect, but from the right side or the left side, it's a bit lower. So would you check on the course, panel view, 3 cusp?
Would you like to check the core panel view? It's okay. But from the core panel view regularly looks this side looks deep.
好来，打到左
core panel 打到左边去嘛。
打左边，看看左关斗，透视，
So because we have only 1 hour, we also
对吧？上
we have only 1 hour. We have one more procedure about the mitral edge repair.
Okay.
So
照啊，
so what do you think?
可以了吧？
保存
照影。
Okay.
Okay. Good. I think the position is.
来，再打回来。I think the position right here is good.
I think so.
Yeah.
Okay.
Yes.
Okay.
So we
The
will
non-coronary side, the possibility is 0 to
Yes.
0.5 millimeter. Stop pacing, please.
Good. Good. Oh, good. Perfect.
Yeah. Okay.
And it did center itself, the
Yes, you
nine
will.
dropped
Yeah,
a little bit.
That was.
So the blood pressure is quite stable. You know, if still a little diving, but not much. So now,
哎，等一下，来，来，
插进来。
来，这个先拿掉啊。The sheath is not so good.
The sheet is
来
not
换一
so
个大鞘
qualified.
来。
就插进来再说，把这插进来再说。
Yeah. 来，拉一下，导师来一个。
OK，
可以了，没事。
那么那个拿过来，那个纱布拿过来。
后视啊。So right now the quality of the sheath is not so good. Yeah. OK， 好了，可以，好，
Good.
没事。来，啊，都是。好了，
Okay.
来换一个大鞘，来。
Good. Okay. Could you show us the hemodynamics or air index or?
The blood pressure is 94/35, and heart rate is 73.
剪掉线条，好了，我是吗？
Can you show us the echo?
The saturation is 100%.
来吧，都是。好了，准备好了吗？
可能输一点液体，接着速度加快点
问。题不大，
血压收缩要一点低。
还可以。
Professor Wang, is that
So,
is
shall we-
echo available?
好了吗？
So and the Dr. Wang is echo any echo image is available?
啊，出来了，出来了。
Yes, echoes are available, but we don't do the TE. We need the TE. Yes, we have echo doctors nearby.
Or just an aortogram.
来，进来吧。
At a very low
I think,
diastolic
what do you think the
pressure.
post-dilatation? I would like to have your comments about the post-dilatation. What do you
So
think?
I think at this stage, after the checking the aortogram and then the deciding the further dilation would
okay,
be
good.
much reasonable.
But from the image, from the fluoral image, so
啊，球上去。
looks the device has not been fully opened.
It's a little constrained there at the
Yes, you're right.
leaflets.
那超声做一下吧，
超声看一看，
心包有没有什么东西啊？
没有问题。
左室太小，他打了他打了3枪。
So this
Yes,
is
now could you see the echo
26.
TT image?
There's some
Could you
regurgitation.
see the echo?
This is transthoracic echo.
Yes.
Yes, chest thoracic echo,
Yes.
TTE.
TTE.
So it's three chamber view. Now it's a three chamber view, I think.
Yes, there are some problems.
So he will measure the velocity. Now the blood pressure is 112 over 40.
We can see there's some revegetation. I think we should need the post-dilatation.
Yes, agree with that.
Yeah. 我们扩掉吧，王老师。来，透视，来，透视王老师，透视一下王老师。
So we are going to do the post-dilatation.
Yeah, what size is the balloon? 26?
23.
23. Still
The
the
same. The same balloon.
the same balloon.
Yes. Yeah, so because the 26 millimeter venous A plus, the waist is 23. Yeah, so we use the 23
就
millimeter.
保持在这里吧。好，准备起搏吧。100，180，
取消联动啊。
相连的啊，180。
好 ，OK， 可以。
Okay.
Frame
停起
open
搏
up.，
停起搏。说停就停。好，我说了，你那个扶一下。好。
And the main determinant factor for post-dilation is the shape of the valve.
血压看了，血压
It definitely opened up on the left side.
换诸位来，来，超声再准备看一眼。
So the constraint of the device
稍微等一下，建明，那个
Looks better.
稍微等一下，我诸位先放进来。
它反流多重啊？刚才。
对，好。
So now we put the pigtail in the
Okay.
left ventricle.
好 ，OK，
Then we do the
Okay.
angiogram
好
and also measure the pressure gradient.
，Yes。做吧，超声。
Professor Wang, I have a very simple question. That by your console
thank you.
solution, just wonder if you choose the balloon size with the smaller one, without without impinge or remain have a leak, would you go for a large size THV, or you will do a large size balloon again? Just wonder, would you cause?
Now we select, we modified our Hangzhou solution. Now we select the balloon size, which is closest to the annular size, but a little smaller than the annular size. Because as you know, we don't need to use the balloon size bigger than, which is bigger than annular. There's no meaning. So now regularly we select the balloon which is very close to the annular size, but smaller than annular.
Yeah. So basically, you only do one balloon sizing.
Only one time balloon,
Yes.
one-time balloon sizing.
Thank you.
There's no gradient,
So
right?
gradient, pressure gradient is gone.
Yeah.
It's,
Of 130.
disappears.
Yeah.
It's gone.
好，
So now we do an angiogram, and same time, if you like, we can do the echo to see whether the regurgitation is still there or it's improved.
OK。
So now we are going to do the
Final
angiogram.
shot.
Final shot, maybe.
好，等一下啊，我再
There
接
was
回
some
去。
by the echo.
Okay, can you show us the
不点一二
angiogram?
三
Yes, to do the angiogram. 好，15联动。好，可以，please。
So now the final shot.
Okay.
You
Good,
see that?
good.
No
Yes,
much
yes.
regurgitation.
Yes.
Only a little.
Yeah, the position is good.
Position is
Mild
very good.
rotation.
So I think the position is excellent. Yes.
All right, mild
Previous,
regurgitation.
yeah, mild,
The QRS pattern is quite narrow. QRS is narrow, very narrow.
Good. Very nice result.
I think we have to move to next
We
category.
go to the next, to
Okay,
the
okay,
mitral
got it.
case. Mitral case.
Yes.
So, and I think the result is very excellent. You put the venous A plus valve using the caustic overlap view, and he tried to 3 times reposition try to put the high implantation, and the result is excellent. And there is just a mild AR. So, and we moved to the second case in using the TEER case.
First of all, just wondering, when you comparing to the boring sample and also serviceable in treating patients with bicuspid valve, what would your strategy?
Yeah, I think it's some center is predominantly use the Evolut self-expandable system. In our center, it's predominantly used Sapien is balloon expandable valve, and I think regardless of the amount of calcium, we try to the experience was accumulated, and the technique as well as device development is so fast, and even though we try to put the implant, the Sapien valve is a very high amount of the calcium in the bicuspid valve, and the overall result is excellent. Is some depend on the center experience and the operating experience?
Yes. Personally, I also prefer the boring sample given that we are able to control the expansion oversize percentage and to avoid the rupture.
Yeah, absolutely.
And would like to get as better as possible to improve the polarity.
Yeah, absolutely. So in the James, and how about Northwestern is for calcified bicuspid valve, and which device and what is your strategy?
We're biased towards the balloon expanding. We think maybe it seals a little better. The exception would be a very small annulus, where you might get a larger size valve in with the self-expanding. So if it's a very small annulus, I might prefer self-expanding.
Self-expanding.
But for most, we used balloon expanding to feel like more reliable seal.
Okay.
Professor Liu, we saw the caster.
Okay, Professor Liu, and can you hear us? Okay.
Right here, right now.
Yes. So welcome you to
The second case.
to the other cast lab. So we are going to do a lab demo
Yes.
about the mitral edge-to-edge repair.
Absolutely. For your the second case and the TEER, and in this session we invited the expert in the TEER, and there is the echo specialist and the interventional cardiologist, the specialist for TEER. Okay, Dr. Song, can you guide?
Welcome, Professor Song.
Yes, Professor Liu, can you introduce us the case?
Yes, sure.
Yes, Dr. Liu, please.
对，王书记慢慢做，我先介绍。把幻灯片放大一点，因为时间比较有限。幻灯片我看不到。幻灯片放到那个超声这个屏幕。对，放大一点。
系统再出来点。啊。
幻灯片放大一点。Okay. The patient is a 87 years old gentleman. The patient has the symptom over 3 years. The patient has the history of hypertension and the PCI. Next one, please.
这没冲。
Next one, please.
气泡。
再往下走啊。And the patient is a symptomatic DMR patient. Next one, please.
We cannot see your slide.
We don't see the echo images.
Okay, can you show us the slide?
你把超声给他们
你把
看。
那个
Presentation slide?
share 一下
看的啊。
他看不到幻灯啊。
对。
你幻灯共享一下，好吗 ？Okay, can you see the slides right now?
Not yet.
来 share 一下啊
回。到中间去吧。在前面了。你盯到肩部啊？你没盯到肩部啊？
现在共享了吗 ？Okay, can you see the slides right now?
Not yet.
No.
Not yet, and there is a.
转播公司看看。
跟那个 ACT 有没有做？
Or can you show us the echo?
在这里，你看这里好像是有一点，算了，去动它是吧？
Okay, yeah, we can see the TE. 来，直接把那个我们把前面做的那个录像拿出来看一下，好吧
谁？在做？
这边你
左方没
拿出来
打，，
先不用看这个啊，
左方打了不大，主动脉打了太大。
就从这里看。Can you see the TE right now?
Okay.
Yes.
Okay, good.
Yeah. The patient is P1 to P2 prolapse. Yeah. 然后你把这个 color 打出来。
它是
And the leaflet is long enough. So we would like to use the Dragonfly system. We will use the long and wide device for this patient. Yeah, so you know, the Dragonfly system is the first transfemoral edge-to-edge tear device in China. And Professor Wang leading our team working together with the engineer together to develop this device. Right now, the device have already finished the clinical trial in China with the DMR and FMR. And we think it will be approved by the CFDA in the late of this year. I think the mechanism is quite similar with the Matchcliff and the Pascal. So however, there are some innovations, including the spacer design, and also you can see right here the stabilizer and the readable parameters. Yeah, there are so many changes. Yeah.
So
Okay, Professor
how
Wang.
many clip size will Dragonfly have? It's also 4 size, so
4 sizes. Yeah, long, short, narrow, and wide. And it can grasp it independently and can check the gradient simultaneously.
So now we are moving to
yeah, we also have very discrete panels to tier expert. So we'd like to have opinion from our panelists. Kubo?
Yes.
Okay.
Thank you, Dr. Wang. This is Kubo.
还可以往前走。
I think that this is a rather bit perhaps. So I think that the long and wide type of the clip is enough for the control. But I think that the challenge point in this patient is a very small left
我觉得
atrium.
还有那个
So if we use a mitral clip device, we have to use the A knob to get the height. So I'm very enjoy your procedure. How do you get the height using the Dragonfly device?
现在到哪里去了？
So
Yeah, the height I think is similar with the Matchcliff system.
小心记到
And how much
Yeah,
height did you
for the-
get on the
让
transeptal?
我往后打一点啊。
Yeah, for this patient we have the 3.8.
后面还
Yeah,
有
so
空间吗？
because of the
后面还有空间吗？
so we cannot achieve higher.
我往后面一点吧。
yeah, Dr. Kang, for patient with limited atrium size, what would you
后面还有
prefer
空间吗
for this case? Would you still go
你找
for
不到了。
the long arm clip?
Warfarin
I think so. It's a lateral.
啊，
It's a lateral defect, so
可以再打。
you might get away with a little less
加一点。
height.
Yeah. Yes.
So, if this is a mitral clip, it would be an XTW.
so the
I have no
the
experience with the Dragonfly.
is very easy for manipulating.
I also
So
would
before you
think,
achieve,
XTW, it will be okay.
before you
More
achieve
than
the
2 or 3, more
overriding
than 2,
totally,
maybe we
you still
get
can
opportunity will rise, but I think it will be acceptable.
Yes, but would you make any difference
Okay,
if the
你扫到肩部，扫到肩部，
pathology
不要去
is
左向，
nearby, is
你
the
们去左向。
commercial or just
你把那
median
个扫清楚。
P1 region? Would you also
把那个
still
左向上，我回应到左
prefer
向。
the long arm if the clip
Hello,
length
hi,
is good, long enough?
Yeah, we are much thinking about that. Yeah, for lateral
你
region.
你看看
and
有没有
longer
在左向，你把
when
左
you
向
want,
打出
but
来，
have
在不在
some
左向？
more complication with the
就担
long
心在
clips,
左向。
so have some difficulties.
啊，
Yeah, it can be harder to get the
往
bigger
后往前打一点。
devices in if it's tucked into the
现在
commercial.
你 device 呢？
Tangled in cords,
那个
Yes.
may choose a shorter device.
我再
Yes,
说。
especially for this patient with very
稍微
small
大一点
area.
吧。
If you would like to retrieve, invert the clip, withdraw to the left atrium, it would be a problem.
到后面的
But given that this patient have actually
Yeah,
medial
that's a
P1
stadium,
region,
stadium.
so maybe the long arm clip may work for this
Should be
patient.
okay.
So Professor Wang, are you
Not
in the
sure, sir.
position?
No, not yet.
Position.
So the
We just see
还要打
fluoroscopy.
完，还要打完。
但是我们要出来一点的。 它这个看不到这个尖啊，
现在已经快到了啊，已经快到那个。
你没有 overset， 还差一点
Dr.
点
Wang, how
overset。
was the mitral valve area measured by 3D or something?
太厚了。
不，你今天这个左防特别打不出来，我觉得
它比较小。
左防打那么小，所以你就是不是我们这个往后一点，这个往前一点。
Okay, the EP shows the echocardiography view and the bilateral. It would be much helpful.
你这个mitral
The trans-esophageal echo view.
已经 overriding 了吗？
Professor Wang, are you overlapping the clip arm?
Yes.
Oh, okay. Can we also have the echo images?
No.
Yes, we already achieved the overriding now.
Yes, it's straddle. Okay, good.
Straddle is okay.
Yes.
Okay.
打回来。
他这个老是
图像打好啊，这边。
你图来了。
Can we have echo on the main screen?
来把这个超声放到大屏幕。
Oh, there it is in the bottom left.
超声放到大屏幕啊。
We can go further the whole system.
它外面能听得到吗？啊，可以了。OK，
偏向3区的，偏 A 区的。
Yeah.
对，它1区啊。
我们再往外移一点嘛。
对，可以。
Yeah, it looks like the trajectory
整
is
体往里面
fine.
近一点。
Or you can also release some M node.
稍放一点看，
Okay, they're moving
差不多
lateral.
了吧？
好，可以。
差不多。So now we can try the trajectory. Any comments?
Yeah,
Right now?
looks a bit median dive.
但是它这个前叶的 leaflet 没有显示清楚，你晓得吧？信不信？你这个 anterior leaflet 没有 prolong， 你只扫到主动脉根部，这个就
Yeah, too much median dive.
或者我们把这个再上一点，大桥把这个扣住，把这大桥也可以再
往后退一点，然后把 M 键松一点。
键已经松了不少了。
那它还是往2区走。Yeah, much better.
Yes.
我再试一下 trajectory. Yeah, the trajectory is much better.
Yeah, that's great.
Yes.
Maybe we need to.
Yeah, we probably can go for
我们先打开看一下。Open.
the orientation.
行啊。
Orientation, yes, we check the orientation. 也看看 orientation 怎么样。还得转一点。哇塞。I needed to
We need to clockwise.
Lock it and
但是它幅度不能太大，
这里很大的一点。
幅度不能太大，它这个高度不够。
我给他，你这里很大的距离。
对。
你到 X plane 看一下，看看那个，那还是在半上的，它这里，你在那个 LVOT， 在半上没有问题。
对。
会。你回到水底 and fast，go back。这个前叶的根部只看到，没有看到它的。
转过来一点了。
Yes.
So
Yes, much
coming,
better.
it's much better. Alignment becomes much better.
Yeah. We still need some.
So could you show us the flow? Color is on, please. 血是从这边出来的，我看。Oh.
Yeah, I think you're splitting the jet.
So maybe it's too lateral. I think we need a.
I see maybe not yet get a true correct orientation.
Yes, should more clockwise.
Clock a
哦，
little.
他没打清楚，
还没打清楚。
新闻没打清楚，打清楚啊。Yeah, looks good.
We are worried about when the device is down to the left ventricle.
The color 看看。
It will too much clockwise. We are worried about. 它前面没切到。
它 color 应该是中间分开了。
它从这个地方上来的问题就是这里有一股。
它可以到二维再看一眼。二维再看一个 color。
可能要。
那你看 color。
Yeah,
what do you think of the position?
Yeah,
We need
position
more
is fine.
media. I think we need more media.
应该是可以
Mr.
的。
Lateral is missing the jet.
Yes. Just would like to get the correct orientation because you have a long arm clip. While you are diving into the left ventricle, it might not be easy to retrieve it.
Explain 的行不行？应该位置还可以了，我觉得。
Yes.
Maybe one clip is not
Yeah.
not enough, so we need more
Yeah.
we need more media a little bit.
OK，
We need a little bit more media.
再到
Yes.
你 orientation 再 check 一下。
Yeah, I think we can follow the
Orientation should be
color
fine, should be
on the
fine.
bicomitional view.
Yes.
你再把 color 打开来，在 commercial view 再。
Yeah， 这个 alignment 可能。Yeah，
没有切好，你把一个 arm 给切掉了，你晓得吗？你没切出来，没切出来这个 arm， 这个左房特别比较小，所以切的房就不够。
角度的问题。
我再靠近瓣膜一点，你可能能切出来。反正现在还有点距离啊。
切出来了已经。那他的 song I think， 他这个的。
Yeah,
The anterior arm is not
yeah, not fully
imaged
open.
well.
Yeah,
It's not imaged well.
I'm just worried about the orientation. It's
可以
probably
再
less
大
than
一点，打
12
大一点
o'clock.
open，他觉得还不够大。
It needs
对，
clock.
其实还
Yeah,
再
you
再
need
转一点。
a big clockwise rotation.
Need the clock.
Yes,
You
yes.
can close it and clockwise.
这个没插紧，是吧
够了，其实可以了。
Yeah.
其实可以了。
I
Yes.
think it should be fine.
对，
should be fine.
再转多了下去就
So
太
when
多
you
了。
are
转回来一点
diving into left ventricle,
Yeah.
the
Yes.
device will keep tension made to be more clockwise, too much clockwise.
差不
Yes.
多了，我觉得
我觉得还转回来了，
可以的。我觉得转回来一点点，可以，差不多了。
在摆这个瓣膜上摆动。哎，为什么老切不出来？你那个
我们打到那个吧 ，explain， 我觉得慢慢可以观想下去一点。
Yeah.
我觉得要稍微往一点来一点。
We can see the passage on the bicomitional view, so
我觉得要
it's
往
quite
一点来
easy
一点，
using
不要太来
the
的。现在
bicomitional
你在
as a
commercial
guide.
这个位
And
置
then
可
we
以，
can, yeah.
好，可以，好，差不多。
这差不多，这差不多。
OK
它有点往。
好，那我们关小一点可以下了。
Yeah.
这样吧。
Yeah, we saw the flare.
So now we are going
Yeah.
down to the left ventricle.
Yes.
No, 稍微往
A
我这
bit
边一点。
medial.
Yeah.
It's a bit medial
可以
dive.
了。哦，他这个不对，他这个要拉出来一点。
Pull back.
你看它整个弯下去了，整个系统，
Too lateral, too
整
lateral,
个系统要出来一点，
Yes.
too lateral.
再好一点，
Yes.
再好一点。
I think it's not needed in the
Probably too deep in the left ventricle.
Yes，
yeah, I think
Too.
好。但是 check 一下 orientation 嘛，不那么急，稍微往后一点。
Would you like to relieve the M not a
Want to go back to 3D and see if
Okay.
your orientation's okay?
Yeah. Yeah.
就 C 的 orientation 来，3D，急不急？我们放这，还是没有。
You're definitely over some of
整
the
个系统本来再
posterior
往外一
file.
点可能好一点，系统还是它有这样下来的感觉。
对我感觉就这样弯下来了，
Yes.
方向还可以。
Okay. Stayed stable.
Yeah. Or
再
possibly
看了打一打，
a bit
切得太深
clockwise.。And then we can.
可以，应该是往
我觉
more
得
lateral。
我觉得我们需要 more media，we need more media。
No, we can. You can
你
guide
外面还可
by
以
the
再加的外
2D, the bicomitional. Yeah, the bicomical can show us the prolapse. So you can use X-plane lateral to the clip.
它叫 explain 嘛，explain，不要把它漏掉。
Turn the camera
Prolapse.
off.
explain，
Well, you're over a big flail there.
Right side. Yeah.
Okay, the
Yes.
posterior is intermittently falling in.
What is
Yeah,
your
there it is.
comments about the alignment and about the position? Is we need more medial or we need more lateral? What is your comment?
I think you can pull back, given that your clip is a bit trajectory, a bit median dive.
Yeah, I'm there.
So you can pull back.
Well, you're clearly over part of the flail here.
Yeah. And probably the flare is
you
lateral
should-
to the clip.
Please check color.
谁在关这个？我觉得现在可以啊。
显影的问题。
你往后一点，
往后一点啊，
后一点，
好，往后一点。
我就上了，啊，
Would you
上了啊。
感觉会不会太靠？
I think that the clip is
Arch.
positioned is between just lateral
saying?
P2 and the medial P2.
Two medial.
So I think that the clip must go to more little bit lateral, because the flare part is the just lateral to the clip.
yes. Given that in the bicam view, you can see the prolapse is lateral to the clip
还要再 lateral， 还要再 lateral，
往里面推一点点。
往这
or
里推一点，
release,
往这推一点，往这推一点，
Maybe just push your system in a little.
and also have
还
to
是 medial 一点了。
可以的。
那我就先上了，下了，
Slightly
上一
median
点啊
dive.，
再往后去，
我已经前面掉出来，差不多了，差不多了。反正掉了，
差不多了。好，
这个是后是吧？
yes.
后面夹住，后面
We
没夹住
don't。have correct angle for the
我在
clip.
想，可能太高
Maybe you
了。
can rotate the
等一下。
bicommercial view, the angle.
没夹住。
对它这个
No,
后
it's
叶
not
也
true.
没夹
It
住。
may not be true.
The posterior is not captured.
前面先打清楚，不要着急。
Yes.
啊，你把它打清楚，要么我们下面一点，再往后移一点或者怎么样，再往下一点，再往后移一点。
可以啊，可以啊。
好，往后下一点，
下一点，
往下一点，你往后移一点，
打一个，好，
啊，那我再兜起来，
好，
好
夹住了。
Good.
OK，good。
，both bouncing,
Yes.
very good。那问题这边还不够 lateral，它有点斜，他妈，它靠近 medial 这来了。
I
Yeah,
just
so we can see clear bouncing from the posterior,
Posterior is
From both
yeah,
bouncing.
prolapse leaflet.
Lifting.
Yes.
yeah, but I am also worried about that it might be at the lateral A2P2 region, but not at the
Okay.
medial P1.
So now we check the orientation again
Yeah, we can check the
to
3D.
see what is going on about the orientation. Not bad,
Yeah.
Not bad.
Yes.
not bad. A little bit clockwise.
Yes.
A little bit
I think
clockwise.
the orientation is good.
Yeah,
A little
it's
clockwise.
fine. It's at a little P1. It's
A
fine. Should
little
be
over
fine.
clockwise.
Yeah. So what do you think of the position? So can you just close to see
Yeah, we can try.
We need color. Can't tell.
color? 颜色看看。Yeah. Okay. So we can just try to
So we
close.
try to
Close.
the
That explain.看到
close
LT.
the,
Yeah, we
the
can go
arm,
to 2D.
close the two arms.
That explain.
Color placing.
It looks like you're on the lateral
Yes.
Release
aspect of
tension.
the jet.
Here.
Just should be at the indentation,
That's
so
right.
this might be fine.
Hmm.
We don't really have
从 medial 来，
the posterior.
要再加也可以再。
其实已经反流已经好很多了，但是你
但
切
是它那个
切好，感觉是不是后叶
会挺多的 ，perhaps 没有了，突 lateral 一点，lateral 一点，但刚才 medial 一点可能就会好一点，
关紧了吗？是
还没到完全到底部。
关紧。
好
好，下面再看一下，check 一下。
For you, so
，so I have tightened to the end.
this part like this.
Yeah, we can check the color and residual
It's
color.
better, become much better.
Yeah. 新北，我觉得你今天这个切面不对呀、
我觉得后面是不是有点？
切了不
是吧？你这个切面打的
信号难道会那么小吗？那个
跟信号小没有关系，你把
信号小没有关系，
把 Cam view 先打出来。
切的时候没有把那个
Yes.
edge 打出，
Yes.
打到主动脉根部去了。
Yeah, yeah, this.
We have to go more lateral.
Much better. Regurgitation
Yeah, it's an indentation.
后叶，把这个后叶。
打的那个叶半叶好像就打不到半叶上，老打到这个，不知道怎么回事。
你 LVLT 那个切面啊，你 Cam view 这个切面先打标准切面先打出来，再然后打到X plane。
Lateral and this.
后叶不舒服。
It's good.
它是我估计你的探头是太往后仰了，你的探头我看你是太往后仰了，往后仰了以后呢，我感到是这个，它不是在2区打的。
我觉得后叶我看一下啊，所以
There's still a lot of posterior prolapse.
overstraddle 了 ，overstraddle 了，那是呀 ，overstraddle 了。把这个大桥往里顶顶，要么大桥
先不能顶，先不能
对吧？这个整个已经都上去了 ，overstraddle。
对。
Can you please check? Oh yeah.
这后叶没夹哦，
那斜了，
这后叶没夹，
这个斜了，顺势。
它还是这个有点 overstraddle。
Yeah, we remain have a large, many prolapse posteriorly.
Yeah，所以我觉得我们还是要拉出来重新来过。
翻起来重新来。
对，你重新那个。
Okay, Professor Wang, and we have remained the lecture, and after hearing the lecture, we will reconnect you, and we're gonna
Okay.
see the final result at the time. Okay?
Sure.
Okay, go ahead. Sure.
Sure.
So, and we're gonna move to the 3 consecutive lecture, and then we will have the discussion time and reconnect Professor Wang final result. And I'm gonna introduce the first lecture, current status of TEER in Korea, and the AMC experience, and Professor Kang.
Yeah, thank you for your introduction. I'm Dr. Do-Yoon from Wacin Medical Center. Today I'll talk about the current status of TEER in Korea with the AMC Wacin Medical Center experience. I will show you our single center experience with some data. So we began the mitral clip 2020 and now using G4 clip. And 9 centers are now performing TEER procedures, so still under the early learning period in Korea. And only mitral clip from Abbott is available in Korea and still not covered by health insurance, so total cost is very high and the major hurdle for the TEER procedure still in Korea. And now about the 9 centers did more than 200 cases, and the major was the degenerative MR. And in Wacin Medical Center, we did the 94 cases, and I will present the data from this 94 case series. And more than half is a degenerative, and about 1/3 is a ventricular functional, and about 13 patients is atrial functional patient. And the 20 among 25 ventricular functional MR patients were the ischemic cardiomyopathy. And there are many numbers, but you can see that the red numbers with the I present the data with the primary MR and not only functional MR but ventricular functional and atrial functional MR, because that 3 MR patient has the distinct characteristics and the hemodynamics. And the patient with the ventricular functional MR is the youngest compared to the primary MR and atrial functional MR, and that has the higher degree of the diabetes and prior MI and PCI history. So we can see that the ventricular functional MR patient is young but has the higher risk profile. And in echo, or as you can expect, the LV ejection fraction is lower, and the LV volume and diameter is higher in ventricular functional MR. And area size is definitely bigger in atrial functional MR, and TR degree, the patient with the moderate or severe TR was the most frequent in the atrial functional MR patient. And the procedural characteristics in our center, we like to implant 2 clips more, so the mean number was 1.7, and in patient with the atrial functional MR, the number was the largest. And the first clip, we in G4 era, we preferred the XTW, and also for the second clip, in primary MR, implanted XTW, and ventricular functional MR, implanted the NT or NTW smaller one. And procedural outcome, and more than 75% patient achieved 1 or 2 plus MR after procedure. However, there are 3 cases of the failed TEER that they moved to the surgical room, but was almost in the early learning periods. One SLDA happened, but stabilized with the additional clip, and one death in ventricular function MR in the patient with acute MR after post-MI patient, but MR was reduced but died with the multi-organ failure. And 2 CVA was happened in 30 days, but all recovered well. The immediate post-TEER echo shows that still low ejection fraction and larger the LV volume and diameter in ventricular functional MR patient. And over the mitral valve area was the 2.4 centimeter and smaller, the most smaller in ventricular functional MR patient. Maybe it would be related to the more aggressive reducing the MR, the degree. It would affect the result. Mean pressure gradient was similar, about 4.5 in almost all patient, and still has the severe TEER at the pulmonary hypertension in most of patient. And I checked the delta of the LV ejection fraction, and the most of patient had a reduction of the LV ejection fraction, mostly in the primary MR patient. And the end diastolic volume was decreased significantly, about 20 millimeter, 20 cc after the procedure. Array size was decreased. However, the immediate post-TEER did not show the significant benefit in TRV max change. Also, I need the longer post-TEER echocardiographic follow-up, but the number is still small, so I will present the data later. And this is 1-year clinical outcome in 94 patients. In 1 year, all-cause death happened in 4% of the patient, and 2 in primary MR, 2 in ventricular MR. And the CV death was the half of the all deaths, and the rehospitalization happened in about 12% of the patient. And 2 additional open heart surgery for MR treatment happened after 9 days for SLDA and after 4 months for the MR progression. And also some subgroup analysis with the treatment of the ischemic heart failure with the severe MR in Asa Medical Center. I did the analysis with the historic, the data with the 20 years of the low ejection fraction, severe MR, and MR caused by the LV ischemia with a wall motion abnormality, and excluded other prolapse or thickening mitral valve pathology. And during the 20 years, and the Asa Medical Center is one of the biggest heart valve surgery center, the total number of the mitral valve surgery plus or minus CABG was only 21 for this indication. Very small number, we were surprised. And we did the TEER actually in 20 patients, but not clinical follow-up is still short, and 14 patients was included in this analysis. And LVAD was done in 7, and transplantation was done in 26 patients. Well, I can assume that many patients underwent transplantation for this indication. And as you can expect, the TEER patient has the oldest age, and the transplantation patient has the most severe symptom. And the TEER patient has the higher the incidence of the preoperative CABG or PCI before the TEER procedure, maybe because of the old age and high risk profile. And the preoperative echo shows that the worst profile in LVAD and heart transplantation patient with a larger volume of the LV. And early mortality was highest in the mitral valve surgery and or CABG. And the TEER showed one mortality as I presented, the acute MR patient, and LVAD heart transplantation patient did not show early mortality. And late outcomes, the mortality was very high also in the mitral valve surgery, and lower in TEER and also in LVAD patient. This is the a very brief Kaplan-Meier curve because the follow-up period of the TEER for this indication of patient is very short, but still we can expect that the patient that underwent heart transplantation has the best outcome for mortality. But TEER also in 1 year and 1.5 year follow-up, it has the good sign for survival in short term, considering the old age of the patient nature. And also the freedom from the MACE with the stroke and death and the myocardial infarction or other surgery, the TEER shows the comparable benefit with the plantation and LVAD. So this data is very preliminary, but we are gathering more data, and with a longer term follow-up, we would be able to show the benefit of the TEER for this kind of a very high risk patient. And I think that for this patient, ischemic heart failure and severe MR, if the revascularization is beneficial, KVG plus surgery or PCI plus TEER would be beneficial, can be benefit the patient, but we do not have the strong data about that. And if it is the revascularization not indicated, maybe we can consider the TEER, especially in this proportionated MR patient. But we do not know that we should select or not to select to consider the TEER for before LVAD or transplantation, and more data is needed. So in summary, in our center experience, patient underwent TEER had distinct clinical and echocardiographic characteristics by the etiology of MR. And TEER showed a favorable echocardiographic and clinical benefit for high-risk patient, but still we are in the early learning period. I expect more we will get more better data after more experience. And TEER showed a lower as an alternative treatment strategy for patients with ischemic cardiomyopathy and severe mitral regurgitation. Thank you for your attention.
Okay, thank you, Professor Kang. And the next speaker is Professor Shih-Hsien, and the TEER for functional MR, and when and how. Professor.
Thank you for the introduction. Following Dr. Kang has presented the advantage of TEER in functional MR in Assam Medical Center, I would like to present the TEER for functional MR, when and how. This is my disclosure. We all know that the severe functional mitral regurgitation is primarily related to myocardial dysfunction, dilatation, the displaced ocular muscle, a poor the leaflet toward the apex, and hence thus hampering the leaflet coaptation. And it would be symmetrical in patients with non-ischemia etiology, and would be majorly involve the posterior median popliteal muscle on the right-hand side in patients with ischemia cardiomyopathy. In the past days, the GYNA only recommended patient to have mitral valve surgery when the patient are going to have concomitant bypass surgery. But the way of treatment has been changed by the COP study. The COP trial recruit patients with heart failure and also 3 and 4 plus MR to randomize to receive TEER procedure on top of medical therapy. The primary endpoint of 2-year heart failure aspiration was reduced by 47% with TEER procedure, and there was 47% reduction in 5-year follow-up with the heart failure aspiration. So the treatment effect persisted. And the TEER can also improve the long-term survival. From the right-hand side, there was 38% reduction in total mortality in 2 years, and also 28% reduction in 5-year mortality. So therefore, the GYNA has proposed new recommendation for patients with severe functional MR when patient remains symptomatic after GDMT and with suitable mitral anatomy, the TEER is recommended. The GDMT includes the medical treatment and revascularization, and also the cardiac resynchronization if left bundle branch block is presented. According to the published data, the significant MR reduction can be achieved in 40% of patients with medication, and also 30% with revascularization, and 50% with cardiac resynchronization, even though we would have more than 40% of patients who are refractory, GDMT refractory severe functional MR patient. So how much the patient can tolerate the GDMT medication? This is the analysis of co-op study showing that there where 38.8% of the patient can tolerate 3 classes of GDMT medication, and only 2.2% of them can be put on maximal dose of GDMT medication. So we would understand these are very sick patients. And there are more than 20% of the patients can only receive 1 or less GDMT class medicine. So the beta block is the most common prescribed medication. And for patients who has only 1 GDMT class, the beta block was prescribed in 88% of them. So these are really sick patients. And also for patients with such tether, posteriorly on the left-hand side, and a large gap between of the coaptation gap on the right-hand side, we actually are not able to expect the medication can really work for this patient, although who are first presenting to my hospital after euvolemia, you still see the hostile mitral anatomy hampering their recovery. So for this is also very challenging anatomy. So for right-hand side, you probably need a bit out hug to get, or use the minus node to get a posterior plate, and resume the positive node to get an anterior plate, to get a very good grasping. But for left side anatomy, you probably are not, even you apply the technique, you are not able to get a posterior plate. You have to close the clip in an acute angle, to use the minus node to get a posterior, and then resume the positive and open the clip to get the anterior leaflet. So these are patients we probably need to treatment as early as possible. How much patient can get benefit from GDMT medication? This is also the data from co-op study. We can understand that about 34.2% of the GDMT group would achieve less than 2 plus MR in 30 days, and 38.1% in 6 months, and 46.9% in 12 months. It seems that there was a gradual increase in MR reduction, but the truth is that these are all the same patient. Actually, it's due to patient attrition to increase the percentage, but not really increase the response patient. So probably we can observe for 1 month to see whether the GDM can work or not. What about the CRT? This is a comparison between CARE heart failure trial and also co-op study. Both devices can improve symptoms and remodel the left ventricle and improve the survival. However, the mitral clip outperforms CRT in the MR reduction, in the number need to treat for heart failure, and also the number need to treat for survival. The procedure-related complication is also less in TEER procedure than the cardiac resynchronization therapy. This is also a patient with non-ischemic heart failure and the bundle branch block. The patient was put on CRT and suffering for 6 months to realize that she cannot get any benefit from the procedure. You can see the gap. So only after the TEER procedure, the patient can really get the symptom, rid of the symptoms. So also in my co-op study, we saw originally relocate to the GDMT group, the patient can get crossed in the black dot line on the right-hand side. You can see the crossover patient can also get similar benefit as the mitral clip group. However, the truth is that more than 40% of them has died within 2 years. They did not get any chance to have the TEER procedure. So this is also our patient, 68 years old, prior MI in cardiogenic shock, and thereafter he suffered repeated heart failure hospitalization. The EF is only 12. The patient cannot have to be stay in the hospital. So at the TEER procedure, we bridge the patient to the candidate for lung transplantation, and patient can be discharged home. They said that our case is also aligned with the mitral bridge registry of about 120 patients with advanced heart failure and 3 or 4 plus MR. Median LV ejection fraction is only 26. The patient may have been on this or are feasible for heart transplantation after the TEER procedure. Although the procedure success rate is less than 90%, but more than 20% of patients can get rid of heart transplantation. And the most impressive is that the 30-day survival is 100%. There was 0 mortality after TEER procedure. This is another patient, 78-year-old man, diabetes, bypass surgery, cardiogenic shock, low ejection fraction, renal failure, acute liver failure, be put on ECMO and IV support. Because the patient, we check the conscious, and then we proceed the TEER procedure. and then the patient can be returned to be rehab 4 months after the index procedure and die 4.5 years after the index procedure. So this is patient with unstable hemodynamics. We also see the data from TAVR Registry about almost 4,000 patients have cardiogenic shock and severe mitral regurgitation. While we go up for the TEER procedure, with procedure success, we can improve the mortality and also the mortality or heart failure aspiration, whether the patient has already been put on mechanical circulatory support or just have been put on the inotropic agent. So this is the recent statement from Europe, from Dr. Hausleiter, that they suggest that for patients with severe symptomatic functional mitral regurgitation, if they have co-op-like profile, we can go for mitral TEER directly. If the patient didn't have the co-op-like profile, we can either go for mitral TEER procedure or go for transplantation, LV assist device, or palliative treatment. I have to, according to the previous public data, the mitral TEER procedure is quite safe. So the most impressive is, again, from the 5-year publication of co-op study, we saw that there was no interaction between subgroup analysis, right, regarding the age, the gender, the ischemia etiology, cardiac resynchronization, functional class, surgical risk, LV ejection fraction. All the patients who has heart failure and symptomatic 3 or 4 plus MR can get benefit from mitral TEER procedure. So this is my conclusion. In selected patients with heart failure and 3 or 4 plus functional mitral regurgitation who remain symptomatic despite GDMT, TEER may provide 5-year survival benefit and also freedom from heart failure aspiration. Benefit has been seen in all the co-op subgroups. For patients with severe functional MR and advanced heart failure with either unstable hemodynamic or versatile mitral anatomy, I believe that TEER still can be the salvage therapy. And early treatment is better, but it's never too late to have a clip. Thank you for listening. Thank you.
Okay, we move to the last lecture, and Professor Junjie Zhang, and welcome. And the title is Safety and Efficacy of TAVR for Pure AR in Native Valve, result from multi-center registry. Okay, Junjie.
Thank you very much for inviting me. It's my great honor to present our season AR trials on behalf of all the investigators. So the aortic regurgitation is the secondary most common valvular heart disease, according to the national survey across China. Among patients with aortic regurgitation, so far the current guidelines still recommended surgical valve replacement as a golden standard treatment. However, among patients with severe native AR, only 20% with LVEF between 30 to 50% and 3% with LVEF less than 30% were referred for surgical aortic valve replacement. So far, we all know the advanced age and the comorbidity were often given as a reason not to offer surgery. Among these patients, an annual mortality of untreated patients with severe AR is up to 20%. For severe aortic stenosis, we all know TAVR is a standard approach, especially for elderly patients. However, compared with AR still challenging because of a large aortic sinus and also the dilated aortic root and also lack of sufficient anchoring, so which will result very prone to the valve pumping out and also the high risk of the PVR after procedure and the high risk of the pacemaker implantation. So thanks to the second and the new generation valve was used compared with the first generation, the new generation valve treated aortic regurgitation was associated with the high rate of device success and the low rate of second valve implantation and also less rate of moderate PV after procedure and also less rate of 30 days mortality. So in the recent 3 years, our center used a self-exam valve for the treatment for the high-risk aortic regurgitation. This is also, you can see the elderly patient presented with heart failure, with a severe aortic regurgitation, you can see the ARV is dilated and also the high risk for SAVA. So this is the CT analysis. You can see the annular diameter is 23 and also the ARV OT 4 millimeter is 30, is dilated ARV. So after CT analysis, decision was made to select the VitaFlow 30 valve for the treatment of this patient. So this patient was treated with TE and the angio guidance under the general anesthesia. This procedure, you can see we use first-generated valve, self-siphon valve. Actually, it's a non-retrievable valve. During the procedure with the TE guidance, you can see when the valve deployed, a little pumping out. At this time, I think we should pull the wire and advance the whole system, avoid the valve pumping out further. And guidance with the TE, we rapidly deploy the valve. You can see this is all the procedure. So the final result shows the valve, the position is good at the, I think at the 0 level, just at the level of the annulus, and without any PVR. And also the valve works is quite good. The patient will discharge at 6 months. You can see the patient would call back to the echo follow-up. The RVF was improved from the baseline 30% to 47%, and also decreased with the RV EDD from the 50 millimeter to 57 millimeter, 70 millimeter to 58 millimeter. This is the second case also with heart failure and severe aortic regurgitation. And according to the CT analysis, we selected the 30 millimeter VitaFlow valve with the oversight index of 1.19. The same procedure under the general anesthesia and with TE guidance, we successfully deployed this is the second generation self-expanded valve. The result is good. This is another case. You can see also very elderly patient with a severe heart failure with severe aortic regurgitation. And also you can see this dilated aortic root. So the decision was still made use VitaFlow 30 millimeter valve. Still with the TE guidance, we successfully deployed the 30 millimeter VitaFlow second generation valve. This is the intraoperative TE guidance. I think for the pure AR TAVI procedure, the TE guidance is quite important. This is a recent live demonstration from our center to the thoracic. This is 84 years gentleman presented with heart failure with a severe AR. This is also CT analysis. The annulus diameter is 28 millimeter, and the LV OT was up to 31 millimeter dilated aortic root. And the decision was made still select the VitaFlow 30 millimeter valve. The final result is good. This is final result. The patient was discharged 3 days after the procedure. So Seok AR trial is including 2 arms. The first arm is the registry arm. We totally included 79 cases from 5 centers from mainland China. And another arm is the randomized arm. Totally, we try to include 201 patients with symptomatic severe AR with high risk for surgery. 1-to-1 ratio to randomize TAVR or GDMT therapy. This trial is ongoing. Today, I would like to report the Seok AR registry arm. So the baseline characteristics, including the mean age was 72-year-old, and also the ST score is 6. It's quite high, and the LVEF is 52%. The CT analysis from the collab, you can see the aortic annulus diameter is 78, and the parameter of the LVOT 4 millimeter below the annulus is 82 millimeter, and also the a little dilated ascending aorta 40 millimeter, and then you can see 75 cases there is no any calcium. According, in terms of the procedural characteristics, all the cases were performed under general anesthesia. All was performed guided with the TEE and from the transfemoral approach. The two devices were used in this registry is all domestic self-expandable valve. Majority, 80% is the first generation valve, Vita Flow and the Venus A valve. The oversize index was 1.15. And see, this is a procedural complication. Of course, mortality only one case. And in terms of the second valve used, the rate is 80%. Quite high for the first generation, 21%. After the second generation valve was used, only one case occurred. The new pacemaker implantation rate is quite high, 27%. Majority were due to the high degree of AVB, 21%. I think a majority due to the high rate of over-index view. At one month follow-up, the of-course mortality was only 1.3%, lower than TVT register result, 12%. But in terms of the pacemaker implantation, still high, 28%. TVT register rate was 80%. So at 6 months follow-up, internal MACE is 36%, which was mainly driven by high rate of pacemaker implantation, 31.6%. But in terms of course mortality and heart failure risk hospitalization is quite low. So in terms of the predictor of the 1 month device success, there is two predictor. One is a STS score, another is aneurysm parameter. And after the ROC calculator, aneurysm parameter predicted the device success. The cutoff value was 80 millimeter. So according to the cutoff value, the group is divided in two groups, the big size aneurysm group and the small aneurysm type. Compared with a big aneurysm type, small aneurysm you can see associated with a lower rate of MACE at 6 months follow-up, which was mainly occur in hospital. Very interesting, 42 cases was completed with echo follow-up. You can see compared with the baseline TE, 6 months TE follow-up was associated with significantly improved RV function and decreased RV size and also the left ventricular size. This is the CDR trial. This is ongoing. Totally, we have included 80 cases. So, ladies and gentlemen, let's take conclusion. Transfemoral TAVR procedure with self-expanding valve could be considered an option in pure severe AR, not suitable for surgery, with acceptable device success, but with increased new pacemaker implantation and improved RV function after TAVR. Device success and clinical efficacy could be improved significantly in AR patients with appropriate aneurysm parameter. CDNA trial is ongoing to demonstrate the benefit of TAVR for pure AR with a high risk for surgery. Of course, the dedicated TAVR procedure device with transfemoral approach needed to be developed for pure AR. Thanks for your attention.
Thank you, Professor Zhang. And the people discussion, we are the Dr. Professor Wang in the Zhejiang University is waiting for showing the final result. Okay, Dr. Liu, can you showing the final result?
Okay, sure. Professor Park.
Okay. Okay.
Yeah.
We are watching.
Yeah, so yeah. We already finished the procedure. Yeah. Okay. Okay, so this is the orientation of the device, the dragonfly. Yeah, 再下来. Okay, then we pull it up, and this is down the grip. Yeah, I think we have the much leaflet long enough. Yeah, you can see the bouncing right here. 再看清楚啊，在前面这里啊。Yeah, so you can see right here, the orientation we think is good, and the posterior leaflet and yeah, it is good enough, right? Yeah, and then we close gradually. Yeah, 再往下走。再往下走。And then we can see there's almost no regurgitation. And the gradient, and the gradient looks good, about 4 to 2 millimercury. Yeah, so, and we check there's no residual prolapse. So then we release the valve. Yeah, after the total release, yeah, you can see right here, the orientation changed a little bit. So however, yeah, there's only the trace, I think there's only trace regurgitation. And also the blood flow of the pulmonary vein is good. Yeah, then we finish the procedure. Yeah, so actually, just after the professor comes, yeah, the presentation, we already finished the case. Okay, thank you so much.
Congratulations for a very successful case. We saw that the treatment for using the dragonfly to treat the central lesion is quite impressive. Thank you. Congratulations. Thank you.
Okay, thank you. Thank you.
Thank you. Thank you so much.
Thank you. So we have at least 10-minute discussion time. Any question, any comment to the presenter?
Dr. Kang, thank you for your nice presentation. Is there any difference regarding residual MR grade among the three etiologies?
In our, although it's a small data, there was no difference between three etiologies. It was about 4 in the average and no difference.
Dr. Kang, I have one question. Thank you for your nice lecture. As you mentioned, the secondary MR, especially in HRMR, the concomitant TR is not uncommon. After the M-TEER, how about the fate of the TR? Do you have any data?
The degree of TR, in patient with the moderate or severe, the TR, baseline TR patient, it was similar even after the mitral, the TR was similar after mitral TR procedure. However, in patients that underwent longer term follow-up more than 6 months, the number was small, so I did not present, but the reduction in pulmonary artery pressure was significant. So.
Yeah, I think the TR reduction might also related to the annulus, whether the tricuspid annulus is dilated or not. That given that almost all the patient can get improvement in pulmonary pressure, so therefore the TR might be really to be improved in patients who did not have dilated annulus. But for patients who already get dilated annulus, probably not a reason.
Okay. One question for Dr. Zhang. What is the reason the vital flow valve seems to work better than the other self-expandable valve for AR, for pure AR? Is it because of the radial strength or the shape of the valve? And what percentage of oversizing that you normally do with the AR?
Yeah, very important questions. Actually, so far as for the second generation self-expand valve for the treatment of AR still off-label. We only use the high-risk patient. So in terms of for Vita flow, I think so far, I think the most important thing is the shape. Actually, the shape is tubular, very suitable for the pure AR, especially for the angle zone is annulus and the LVOT. I think for the oversize ratio, our center experience is maybe 1.1 to 1.15. It's suitable. If too high, maybe increased risk of a pacemaker implantation. In the early stage, actually, you can see the pacemaker implantation is quite high, nearly 30%. Recently, actually, you can see even the live demonstrate the oversize ratio only 1.1, something like. Actually, all the cases, the pacemaker implantation rate decreased to 10%.
Great. My understanding is oversizing index, that means 1.1 is a 10% perimeter oversizing, right?
That's right, yeah.
Okay, wow.
Yeah.
So I think the result is very excellent. Moderator and the severe PVR is just 2.5%. I think this is dramatic, very nice result. It's very provocative result. So we still don't have experience of the VitaFlow 2, and is some much different is compared to venous AFib or Evolut R system. And during the procedure, usually pure AR has there is no combined calcification. Could you comment on the anchoring problem? In China, is J-valve is available. They use them. Try for some anchoring system for aortic root, but this VitaFlow 2, there is no, seems like no anchoring system. Could you comment on how do you anchoring well enlarge the, aortic, the annulus area? That is my key question.
Yes, thank you very much, Dr. Park. It's also very important questions. So far, still, I think the CT analysis is very, very important for the patient selection. I think the biggest size of annulus parameter is 85 millimeter so far for VitaFlow. Under this point, I think the oversight ratio may be 1.1, something like that. And another important is LVOT, the diameter. Still, I think the ratio between the LVOT 4 millimeter diameter and to the annulus should be between the 0.95 and the 1.05. It's tuber, which this kind of anatomic will be suitable for VitaFlow. So beyond this, if this case have undilatable ascending aorta, something like ascending aorta diameter less than 38, it will be more comfortable. But only these two levels, annulus level and the LV2 level, is enough for the anchoring zone for the VitaFlow. That's my experience. Yeah.
Dr. Zhang, I have one more question. But in your presentation, the patient with over larger annulus, over 80, had a poor survival, right?
Pardon?
Yeah, the patient with over larger annulus area had a poor survival.
Yeah, that's right.
Do you think why? But which parameters were different between the two groups? Ejection fraction or other echo parameters were different between the two groups?
I think this result is from the very early results. The majority of devices will use the first generation. So first generation cannot be retrievable. I think the reason is the high rate of second valve implantation, because the majority valve will use first generation. After the second generation, actually quite a low second valve used. And also the position is quite good, and also a low rate of pacemaker implantation.
Especially in patients with severe AR, in patients with depressed ejection fraction usually have larger annulus area than
I think so.
Without,
with large annulus also associated with low LVEF and also dilated LVEF. So that's the point that we should treat it at the right point for the patient. To end age, maybe definitely associated with a poor outcome. Yeah.
Is VitaFlow can work for severe AS, some calcified severe AS?
Yeah, actually, this is a traditional indication for VitaFlow. Yeah. Thank you.
Okay. Any question? Okay. Any comment? Okay. So the time is already done, and thank you very much all the panel and all presenter and also Professor Wang in the China team for showing the very excellent live case demonstration. So we're gonna finish, and today the last session. Tomorrow we will start 8:30 a.m. With a live case from the Cedars-Sinai Hospital, and tomorrow we prepared very interesting complex TAVR case as well as a TEER case. Thank you for joining the last session. Thank you.